I'd just like to say that I'm honored to be here for two reasons. One is that it's kind of scary to share the podium with some very major leaders in MS and other areas of neurology. And these people were leaders when I was still in neurology school, as Dr. Mandler would say. And the other reason is just that I value my association with this organization. Every time I deal with people here, you know, there's honor, there's joy here, the joy of fellowship and meeting other people with this illness. Just to see Mr. Gilmore get up here and approach the whole topic of caregiver issues with humor. There's intellectual curiosity and a desire to know, and just a lot of real strength, so I'm happy to be here. I come as a person, just a clinician who mainly takes care of people with MS. And whenever you have a MS clinic, people come in with transverse myelitis. So I'm going to talk a little bit about the connection. And some of this I gave at the 1999 Symposium, and then I have some new data. Why look at MS? Well, MS is a demyelinating disease, an inflammatory disease where myelin is lost, insulation of the nerves. And many people believe that acute transverse myelitis is part of a spectrum of diseases of CNS demyelination. And that maybe if we look at MS, we can unravel some of the information about transverse myelitis that's eluded us. So basically, transverse myelitis will fall into the clinical category of neuroimmunology, and the specialists who will be most interested in investigation will include those who specialize in MS. And if you look at the setup of an academic neurology department, you'll find a subdivision in most centers with one or two or more, for places that are lucky, specialists in MS. There are possible similarities in etiology, pathophysiology, and clinical features between transverse myelitis and MS. And what I'm really going to focus on is the fact that transverse myelitis may be a first attack of MS. So that's a small subgroup of people with transverse myelitis, and I don't want everyone to sit here and wonder whether they have to deal with the possibility of MS, but we still need to address it and trying to learn about MS. And Dr. Weinschenker, who's here to talk tomorrow, has said that MS is almost certainly not a single disease, but a series of IIDDs, idiopathic inflammatory demyelinating diseases. And so transverse myelitis is placed in that spectrum and has a poorly defined relationship to MS. As other speakers have said, the incidence of MS is very common, very high, and transverse myelitis relatively uncommon, almost rare, but not quite. And if you look at the difference, MS varies with geography, and we've had some discussions about that, trying to look at transverse myelitis. And in the U.S., the incidence will vary from 10 per 100,000 to over 100 per 100,000. But for TM, it's still 1 to 5 per million. So you can see the relative frequency. Now, in MS clinic, when people give you their history, if you go back and ask them about their first attack, 40 to 50%, so let's say half, of the first attacks were monosymptomatic. Okay, so if someone has a first attack of MS, they can have a whole gamish of things happen at once, like have double vision and loss of vision and weakness, or they can just sort of have one pure presentation. And an example of that might be opticneuritis, where one eye loses vision just because there's a single area of demyelination in the optic nerve that takes information from the eye back to the brain, or they could have a single lesion in the spinal cord. So we're going to look at some of those single monosymptomatic, one symptom presentations. Spinal cord involvement or attacks are common in MS, but the syndrome of just having a complete acute transverse myelitis that completely knocks out the spinal cord is unusual as a first attack. And in one population study, only less than 1% in a Canadian population study had acute transverse myelitis as their first attack. But as Dr. Mandler said, that there's a wide variation in the studies, and there's certainly higher rates in some studies for myelitis as the first attack. Now, I'm going to jump to optic neuritis for a bit because we know more about it. There is more information, more people have been studied with optic neuritis, but it's analogous to transverse myelitis because it's a single monosymptomatic presentation of MS where there's acute inflammation or demyelination of the optic nerve, and just like transverse myelitis, it can vary in severity from total blindness to just a vague blurring. This prognosis for this event is very good. The majority of people have almost near total recovery of vision within weeks to months. And we know in this case that IV steroids hasten recovery. And this is sort of a summary of some of the studies that have been done, not all of them, but a good number, looking at people who come in with just optic neuritis, monosymptomatic presentation. And what we know from these studies is that looking at the MRI of the brain can give us an idea about the prognosis or the chance that these individuals are going to go on to have a second attack of demyelination somewhere else in the brain or spinal cord that would lead to a diagnosis of clinically definite MS. Multiple sclerosis, multiple attacks. So in general, we're debating about the definitions of MS, but the classic definition is you have to have 2 or more attacks. So if you look at all of these studies, what you'll see is if the person has a normal MRI when they first come in, then they have a very low risk of going on to develop MS. Now, this is all dependent in some ways, or the data is important on how long did they follow these people. Did they just follow them for 2 years or 10 years? And obviously, we're more interested in studies that have gone for 10 years or so. If there was an abnormal brain MRI, i.e. if there were white matter lesions in the brain, then there's a higher risk of developing a second attack down the road that would classify as MS. And so this is all less than 10% normal MRI, so a lot of fluctuation, but let's say sort of averaging out to 40% or so. And this Larry Jacobs study is the most recent. He's presented an update and collected more people, up to 74. And his numbers are that 57% had an abnormal brain MRI when they came in with optic neuritis. So then, now that we sort of looked at optic neuritis as an example, let's go back to TM and say, what are the prognostic factors that we might know something about? And one is this issue about complete versus partial myelopathy, okay? So what I mean by that, if it's complete, the spinal cord is completely knocked out, total paralysis, total loss of sensation, versus just partial, weakness but not complete paralysis, maybe some alterations in sensation, but not, can't feel anything. And then symmetry versus asymmetry of motor and sensory abnormalities. And what I mean by that is if there's weakness in one leg, is there the same degree of weakness in the other? Is it symmetrical? And same with the sensory. We know some things about cerebral fluid abnormalities that I'll come to, and then certain features of MRI imaging of the brain spinal cord may give us a clue about a person's risk to person with TM, their risk to develop MS down the road. Okay, so looking at this question of complete versus incomplete, this comes out of very small studies of transverse myelitis, but basically one study reported that if there was complete transverse myelitis, only 2.9% of patients convert to MS. And variable follow-up period. And then in another study, 12 of 15 patients with partial converted. Now that's a pretty high rate, but it underscores the difference in prognosis between complete and partial. And then there's the question of symmetry and asymmetry. And Scott and his group followed patients with acute TM and noted that 15 out of 16 patients with acute myelopathic MS had asymmetric findings, but all the patients with TM had symmetric motor loss, and most of them had symmetric sensory loss. So if there's symmetry, that goes along more with a TM that's not going to turn into MS. If there's marked asymmetry between halves of the body, that has a higher prognosticator for MS. Looking at the spinal fluid, the things that we look for besides indicators of inflammation, cell count, and elevated protein are also antibodies that may cross the blood-brain barrier and leak into the spinal fluid. And in one study of 183 patients with this one symptom MS, a single attack, followed over time, 24% with oligoclonal bands, or one type of abnormal antibody in the spinal fluid, versus only 9% without developed definite MS. And in other studies, there's been a stronger correlation. This doesn't help you in any individual, because people without oligoclonal bands can develop MS, but it's just a relative weighter. Okay, and then looking at spinal MRIs, the studies that have been done suggest that if you look at inflammation in the spinal cord by MRI, there's no specific findings that can help you distinguish MS from acute TM. There's some weak things, like swelling of the cord is more commonly seen in acute TM, but may also be seen in MS. And it's more often that you see multifocal lesions. So, a lesion at the C5 level, and then the C7 level, and the T1 level, sort of skipped multiple separate lesions, are more common in MS compared to acute TM, which will often just have one big confluent lesion down the cord. So the spinal MRI won't help us too much. Although we have better software now to look at things like the volume of the lesions and the size of the cord and all. So maybe more will come out of that with more detailed study. So what about the brain? And that's what I'm going to speak about for the rest of the talk, is that the cerebral MRI can help us very significantly decide who's at a higher risk to develop MS down the road. There are small studies of patients with monosymptomatic transverse myelitis converting to MS. And remember all the studies I showed you for optic neuritis, and this is more what we have until a recent big study I'm going to tell you about for transverse myelitis. And this small study, there was 12 out of 15 patients had an abnormal MRI, and a small group had normal MRI that developed MS. So you can see that if you have an abnormal MRI, there's a higher risk of MS. And what do I mean by an abnormal MRI? Well, we have different criteria. Different research groups use different criteria of what kind of abnormalities on the brain MRI we consider suggestive of MS. And one of the widely used criteria, the University of British Columbia criteria, where if there's 4 white matter lesions, then that's strongly suggestive. Or if there's 3 white matter lesions, one of which is next to the ventricles or fluid-filled spaces in the middle of the brain, that's suggestive. If they have a larger diameter, or they're predominantly in the white matter, these are the criteria, especially if they have a diameter greater than 6 millimeters, if they have a certain shape, an ovoid shape, that's perpendicular to the plane of the lateral ventricle. If there are lesions in the brain stem that connects the brain proper with the spinal cord, and lesions along the corpus callosum, if there are open rings. Okay, if these kind of lesions are present, those are more strongly suggestive of MS. So knowing that knowledge, that abnormalities on the brain MRI are indicators of a strong likelihood of going on to develop a second attack of demyelination that gets a diagnosis of clinically definite MS. A study was designed to look into this issue in more detail, because now we have drugs that are partially effective in the treatment of MS, the ABC drugs, and they cut down new attacks by about a third. So our question is, well, how early should we start these drugs? We know that we should start them after a person definitely has MS and has 2 attacks, but should we even be starting them if a person has 1 attack, and especially if they have an MRI of the brain with abnormalities that suggest, that they're at high likelihood to have that second attack. So the study I'm going to tell you about is the CHAMPS study, which CHAMPS comes from Controlled High-Risk Avonex MS Prevention Study. Avonex is the brand name for a form of interferon beta 1A, which is one of these standard treatments for relapsing MS. And this is the title of the article that resulted from this study, Intramuscular Interferon Therapy Initiated During a First Demyelinating Event in MS, Larry Jacobs and his group. And this was published in the New England Journal of Medicine in September of 2000. I'm happy to say our group contributed a couple of patients to this effort. And how this CHAMPS study, what were the aims of the study? To look at people with monosymptomatic demyelination, so that's optic neuritis, brainstem or cerebellar events that could have varied manifestations, including double vision or vertigo, other things, and of our interest, spinal cord or myelitis. So those patients, and they also had to have at least two T2 MRI lesions. Okay, everybody uses different criteria, but at least 2 on their screening MRI at the time they came in with their first demyelinating event, because then they're pre-screened to be at high risk to go on to develop MS. And 383 patients were recruited in 50 centers across the U.S. and Canada. And that shows up pretty well. This is just an example of what kind of white matter lesions or abnormalities were needed to be qualified for this study and to also indicate a high risk for developing MS. And so here we have these kind of lesions. This middle space for the non-neurologists here are the ventricles, okay, the lateral ventricles. And these are fluid-filled spaces in the middle of the brain. That's where the spinal fluid's made. And here you can see lesions that tend to line up adjacent to the ventricles, and we can measure their diameters. If you have a lesion that's pointed this way, that's what I mean by perpendicular to the long axis of the ventricles. So this person more than qualifies. There are about 12 lesions there. And the way the study was conducted was patients developed symptoms. Now this was the hard part. You had to get them into treatment in a treatment center within 2 weeks, start high-dose IV steroids, there was an oral taper, and then convince the person, explain to them about demyelination, their risk of MS, and offer them the opportunity to participate in a clinical trial while they're still digesting all of these things that have happened to them. But it was a great trial, and it's a very important question, so people did enter. And then they were randomized to either receive placebo or Avonex, and interferon beta 1A is a medication that's shot once a shot, an intramuscular shot. I mean, it's not an easy pill, once a week. And this study was to go on for 3 years. And then they were followed periodically. And there are more people with optic neuritis, or it's easier to find and identify quickly. And the goal of the study was to have about half of the people have optic neuritis, and more's known, like I said, in the pre-existing literature. Brainstem, about a quarter, and spinal cord, our group, about 21%. And this is a graph to show how people did over time. All right, so here nobody has a diagnosis at the beginning of the study of clinically definite MS. They all came in with one attack. But over time, as you go out through the study in the months, when the lines go up, it means somebody dropped out because they had their second attack and they got a diagnosis of MS. So you can see over time that more people in the placebo group had that second attack during the period of observation than the people treated with interferon beta 1A. And actually during this observation period, it reduced the rate of conversion from a monosymptomatic presentation to clinically definite MS by 44%. And so we can divide this up into subgroups, all right? And if you look at, here's the total group, placebo-treated rate of conversion at 2 years to clinically definite MS versus the Avonex-treated group. Here's the Opticneuritis group, the brainstem group, and the spinal cord group. And there's a big effect here. There were 42 patients here that were on placebo and 41 patients who were on Avonex. This slide, it's actually going to be presented somewhere else, and I kind of begged my way into getting this, these numbers for you before it's presented. But so basically, if you look at these groups, the relative risk for spinal cord between the placebo and Avonex group is 0.3, or being treated with interferon seemed to reduce the risk of having a second attack for these special people with myelitis who had abnormal brain MRIs by about 70%. And then everybody in the study had periodic MRIs to monitor whether they were accumulating new lesions by MRI over time. Now, for the optic neuritis and brainstem cerebellar subgroups, there was a significant difference between the placebo and interferon groups in that the people on placebo accumulated new and more lesions, okay, over time compared to the interferon-treated group. They did not see such a difference in the spinal cord group doing these serial MRIs to measure new lesions. But there was a trend towards significance. And some of that may just be that this was the smallest group. It had the lowest number. And when you're trying to look for results in a clinical trial, the more people you have, the more powerful your study will be to detect these changes. But it's sort of interesting, and they're hashing out what all these subgroup things, observations mean. So I'm trying my best to catch you up and stay on time. The conclusions of the CHAMP study for the overall MS community are that there is some benefit for really early treatment, and starting after the first attack, if there's an MRI of the brain that shows white matter lesions that are strongly suggestive of MS. And so, that's changed our practice, and neurologists are offering these drugs very early, or at least starting to discuss them. For the transverse myelitis group, it suggests, first of all, that we should be getting cranial or brain MRI scans as well as spinal cord. And I do see a lot of people who had transverse myelitis and have never had a brain scan, and sometimes we just do one just to see what's going on there. And then it suggests that in your group, people that have these abnormal lesions on the brain may want to learn more about this study and be considered for treatment. And that's all I have.